Hello everyone, I'm Dr. Prashant, and in this presentation we will talk about hemophagocytic lymphohistiocytosis. Hemophagocytic lymphohistiocytosis is defined as a life-threatening hyperinflammatory condition due to activation of macrophages and increased cytokine production, resulting in multi-system manifestations. This is a schematic diagram of a macrophage or antigen-presenting cell. In the presence of an antigen, the macrophage gets activated. Once its function of presenting the antigen to the T cell is over, it is generally lysed by the CD8 cytotoxic T cell. Similarly, natural killer cell also function to deactivate the activated macrophages or antigen-presenting cells. In hemophagocytic lymphohistiocytosis, there is a defect in T cell function and natural killer cell function. There is increased cytokine production, which results in hypercytokinemia, which is responsible for tissue damage. In absence of these CD8 cytotoxic T cells and natural killer cells, to deactivate the activated macrophages, in HLH, the macrophages now phagocytize or engulf self-tissues such as RBCs and other components in the blood. This is called hemophagocytosis. Hemophagocytic lymphohistiocytosis may be either familial or secondary. Familial HLH may have its onset in infancy and has a mean survival of about 2 months, but it can occur at any age up to the age of 70 years. The genes in familial HLH include FHLH2, MUNC 13.4, STXBP2 or FHLH5, and syntaxin or FHLH4. Causes of secondary HLH include infections such as Epstein-Barr virus, cytomegalovirus, parvovirus B19, herpes simplex virus, and HIV. Secondary HLH may also be due to autoimmune conditions like systemic juvenile idiopathic arthritis, systemic lupus erythematosus, and systemic sclerosis. Secondary HLH may also be due to malignancies such as leukemia and lymphoma, and it may be due to tuberculosis, malaria, enteric fever, and leishmaniasis as well. The diagnostic criteria for hemophagocytic lymphohistiocytosis includes a molecular diagnostic test which is consistent with HLH or more than 5 of the following 8 conditions. These include fever, cytopenias involving 2 or more cell lines, hemoglobin less than 9, neutrophil less than 1000, and a platelet count of less than 1 lakh per cubic millimeter. Splenomegaly is also part of the diagnostic criteria for HLH. Before we move on to the next diagnostic criteria, let us review in brief the T cell receptor and its function. This is the T cell receptor, and this is the antigen being presented in context of the major histocompatibility complex shown in orange. The purple structure is the antigen presenting cell. This is the CD4 molecule which binds or cements this interaction, and once this interaction is complete, the antigen presenting cell now secretes interleukin 1 to stimulate the T cell. At the same time, there has to be co-stimulation by CD28 and B7-1. This prevents the recognition of self-antigens. Let us now move within the T cell. Inside the T cell, once this interaction has happened on the surface, there is increased production of genes for interleukin 2 and the interleukin 2 receptor. The interleukin 2 receptor is now expressed on the surface of the T cell. Interleukin 2 binds to this receptor and T cell activation proceeds. Clonal expansion of T cell occurs in this fashion. This interleukin 2 is also used to diagnose HLH, and a level of more than 2,400 units per ml is diagnostic. The other diagnostic criteria include hypertriglyceridemia, fasting more than 265, increased serum ferritin more than 500 micrograms, and a low natural NK cell activity. The diagnostic criteria for HLH are summarized as shown here. The differential diagnosis for hemophagocytic lymphohistiocytosis includes macrophage activation syndrome. HLH associated with rheumatologic conditions is called macrophage activation syndrome. Other differentials include liver disease or liver failure, multisystem organ dysfunction, autoimmune lymphoproliferative disorders or ALPS, and Kawasaki's disease. The other differential diagnoses include thrombotic microangiopathies, transfusion-associated graft versus host disease, and drug reaction with eosinophilia and systemic symptoms or DRESS syndrome. Before we begin treatment in patients with hemophagocytic lymphohistiocytosis, we have to rule out and treat secondary causes, and we have to treat viral infections or malignancies and stop any offending drugs, and antimicrobial therapy must be used for bacterial infections. Treatment of hemophagocytic lymphohistiocytosis consists of Etoposide, which has been the standard of care for management of this condition for many years. Etoposide is generally administered with Dexamethasone. The other treatment options include Cyclosorine and Tacrolimus. These are immunosuppressive drugs which are used in HLH. We may also use Alemtuzumab CD52 monoclonal antibody in HLH. Alemtuzumab is used as a bridging therapy, and the definitive management of HLH consists of a hematopoietic stem cell transplant, which has revolutionized the treatment of this condition. Response to therapy in HLH is assessed using a reduction in splenic size, lymphadenopathy, improvement in the fever curve, improvement in liver function tests, increased fibrinogen, reduced ferritin, and reduced levels of soluble interleukin-2 receptors. Patients who are receiving treatment for HLH should receive prophylaxis for pneumocystis pneumonia with trimethoprim and sulfamethoxazole, and antiviral prophylaxis with drugs such as acyclovir. The important message in this presentation is that hemophagocytic lymphohistiocytosis is a rapidly fatal condition with a 30-day mortality occurring in 50 to 75% of patients, and the advent of hematopoietic stem cell replacement or bone marrow transplant has revolutionized the treatment of HLH. That's it for our presentation on hemophagocytic lymphohistiocytosis. Thanks for watching, and we will see you in the next video.